So first off, for those who don't know me, my name is Josee or Joe, and I'm one of the third-year FR residents here in Ottawa. And it's my pleasure today to be your Grand Rounds facilitator. I'd like to start things off today for Grand Rounds with a little bit of a case. So I'd like you to picture yourself working in a peripheral hospital near Ottawa. It's late in the evening, and you're wrapping up your last chart of a never-ending parade of URTIs. When you're alerted by the nurses about an incoming patch call for a 65-year-old female presenting with hypotension and tachycardia. You quickly sign off your chart, grab your POCUS machine, and make your way over to the resus bay as the paramedics come walking in right behind you. They provide you with the following handover. You have a 65-year-old female, we're going to call her Doris. She's had a 2-week history of generalized weakness with decreased appetite, nausea, vomiting, diarrhea, and maybe a low-grade fever at home. Paramedics were called to the home this evening because she had a pre-syncope episode while walking from the bathroom to the kitchen while her daughter was over. She has a past medical history significant for type 2 diabetes, peripheral arterial disease, and hypertension, and her meds are listed as on the slide. Her vitals are seen on the right-hand side, and her physical exam is listed on the bottom. So what's going on? I'm sure with that prompt that you probably had a differential in your mind that looked a little bit like this, the so-called hot and bothered differential. However, as you've probably gathered from the objectives of the presentation that were circulated by Rachel, there's a particular entity that should always make it on your differential for this type of presentation, and that is thyroid storm or thyrotoxicosis. And so it should not be a surprise to you today that the objective of our talk today is the hyperactive thyroid. And we will be focusing on 3 overarching objectives. The first will be to go back to basics. We're going to understand the pathophysiology of hyperthyroidism and its many entities. Second, we will review common causes of thyrotoxicosis and its relevancy to the do not miss scenarios in the emergency department. And lastly, we will break down an approach to the management of thyroid storm with input from some local experts. So, without further ado, let's go back to the beginning. As we all know, the pathophysiology of a functioning hypopituitary axis with regards to the thyroid gland is as follows. The hypothalamus releases thyrotropin-releasing hormones, or TRH, that in turn stimulates the anterior pituitary to produce TSH, or thyroid-stimulating hormone. TSH then in turn stimulates the thyroid gland to produce a mixture of T3, or triiodothyronine. That's the only time you'll hear me say that, or it'll be T3 moving forward, and T4, or thyroxine, a step for the synthesis that also requires iodine. The T4 can also, which is considered to be the lesser active of the hormones, is also converted peripherally into T3 in the tissues via deiodination. In times of abundant thyroid hormones, or excess T3 and T4, the thyroid hormones will operate on a negative feedback loop to decrease TRH and TSH synthesis from the hypothalamus and the anterior pituitary gland, respectively. In the case of hyperthyroidism, this homeostatic environment, as described, is interrupted, and there is an excess of T3 and T4. This excess T3 and T4 is formed through 3 primary mechanisms. The first is overproduction of thyroid hormones due to disruption in the actual axis. These causes are often divided up into our classic primary causes of hyperthyroidism and secondary causes of hyperthyroidism. In the primary causes of hyperthyroidism, there's overproduction of thyroid hormones directly from the thyroid gland. This is often what is seen in Graves' disease, where antibodies chronically stimulate the thyroid via TSH receptors to overproduce T3 and T4. In secondary hyperthyroidism, the HPA axis is actually disrupted above the level of the thyroid. For example, in pituitary adenomas, which secrete excess TSH. A second mechanism by which we can get excess thyroid hormones is through exogenous sources. So things such as overdoses from Synthroid, or in certain types of ovarian tumors, such as hydatiform moles. And the third mechanism by which we can get excess thyroid hormones is by direct injury to the thyroid, which leads to direct release of thyroid hormones. And this often occurs in the context of trauma, in the context of inflammation or direct injury from other causes. Ultimately, regardless of the three mechanisms by which you achieve hyperthyroidism, biochemically, an individual with hyperthyroidism will have high levels of T3 and T4. But remember that the degree of elevation of T3, T4 does not translate or dictate to the clinical scenario. In hyperthyroidism, your blood work will also often reveal a low TSH due to the negative feedback loop that we just described, wherein the thyroid hormones exert a negative feedback onto the hypothalamus and the anterior to pituitary gland to decrease TRH and TSH synthesis. However, just a word of caution on that, because in the case of secondary hyperthyroidism, you actually would expect to have a normal to high level of TSH. And so if you have a high clinical suspicion that you may have a patient in front of you who has hyperthyroidism, thyrotoxicosis, or thyroid storm, then make sure to send off your TSH alongside your thyroid hormones up front, because a screening TSH may not be accurate in this moment. And for those who are concerned about costs, the cost of a TSH and a T4 together is the same as sending a troponin. So quite a low cost in comparison to many other things that we do. So we've talked about the biochemical and pathophysiology of hyperthyroidism. Now let's go through a little bit of what you can expect from a clinical perspective. As we all know, hyperthyroidism encompasses a continuum of presentations. On the one end of the spectrum, we have subclinical hyperthyroidism, something that's often just incidentally found, usually by family physicians doing screening blood work. It identifies the states where you're producing less TSH, but there is no impact on your thyroid hormones. And as a result, you have no clinical signs overtly. Next, you have the true hyperthyroidism, which often gets described and intermingled with thyrotoxicosis. But for the purists in the room, hyperthyroidism is really the pathological state in which excess thyroid hormones are produced by the three mechanisms that we already discussed earlier, while thyrotoxicosis is the clinical presentation of that hyperthyroid state. And that thyrotoxicosis, or those clinical syndromes, also exist along a continuum, from just simply having intermittent palpitations all the way to having a very strong thyroid storm. And so last but not least, thyroid storm is a clinical entity that is described with altered mental status and evidence of end organ damage secondary to hyperthyroidism. And this is the one that us as emergency physicians cannot miss in the ED, because if left untreated, literature shows that the mortality rates range from anywhere from 60 to 100%. With treatment, though, we can decrease that mortality rate to 30 to 40%. And so it's very imperative that we as emergency physicians can recognize thyroid storm and treat appropriately, which is why we're all here today. And so we've gone through the continuum of hyperthyroidism. Let's quickly go through some of the primary symptoms that you can expect to see in someone who is in a hyperthyroid state or presenting with evidence of thyrotoxicosis. Ultimately, all of the symptoms are related to the excess thyroid hormones, and specifically T3 that is in the body. And so at a cellular level, T3 actually increases the production of sodium, potassium, ATPase, creating a rise in oxygen consumption and heat production. It also directly stimulates beta-1 receptors of the heart and increases cardiac contractility and heart rate, in addition to stimulating the number of beta-1 receptors available on the myocardium. And last but not least, thyroid hormones have a direct effect on metabolism, increasing glucose absorption, glycogenolysis, and lipolysis. There's actually been a couple of case reports of Wernicke's encephalopathy occurring in individuals with thyroid storm, secondary to hypermetabolism and resulting thiamine deficiencies. Given these three mechanisms, I think it's no surprise to anyone that the primary symptoms that we can expect in a hyperthyroid state are an elevated basal temperature, tachycardia, and weight loss. Other symptoms may include diarrhea and vomiting as well. On exam, if you're dealing with Graves' disease, you may see goiter, exophthalmos, tremors, or pretibial myxedema on presentation. Ultimately, what you need to remember is that hyperthyroidism is evidence of a hyperadrenergic state, and that you should find those clinically on examination in the case of hyperthyroidism, thyrotoxicosis, and thyroid storm. Excuse me, I have the hiccups. In the case of thyroid storm, this hyperadrenergic state is placed into overdrive, as we all know, and creates a hallmark triad of symptoms that include altered mental status, tachycardia, and pyrexia. For an entity to be considered thyroid storm, though, the acutely hyperthyroid state must also lead to end organ damage, and that can range anywhere from damage to the heart, the kidneys, the liver, and more. And so when you're seeing an individual you're concerned about thyroid storm, it's really important to make sure that you send off the appropriate blood work to measure the degree of end organ damage. It's also important to remember that this classic triad of symptoms is not always seen, and that not all thyrotoxic states or thyroid storms present with these classic symptoms. In particular, the entity of apathetic thyrotoxicosis is important to remember. It refers to a clinical syndrome wherein hyperthyroidism presents without typical symptoms of adrenergia. So instead of your hot and crazy persona who exhibits hyperkinesis and mental alertness, you're instead met with an individual who appears to be apathetic or subdued and often can be described as depressed. Clinical presentation may include elements of weakness, memory loss, obtundation, and often will result in evidence of heart failure, just given who is at risk for apathetic thyrotoxicosis and their underlying health state at that time. So although apathetic thyrotoxicosis is listed in Rosen's and listed in all the literature as this rare event, up to 1/3 of thyrotoxicosis or thyroid storm presentations in those aged 65 and up will be apathetic in nature. And in all apathetic presentations, over 80% of those individuals are 65 and up. And so it's important to recognize what risk factors people have to presenting with a non-classic or apathetic presentation of thyrotoxicosis. As you've gathered, age is one of those biggest risk factors, but there's a couple others that we should keep in mind. Those include individuals who cannot achieve the hyperadrenergic state we expect in thyroid storm or thyrotoxicosis. And so those include people who are on beta blockers, individuals with underlying psychiatric disorders, especially those who are on mood stabilizers and may have evidence of mast facies at baseline, in addition to those who have adrenal insufficiency. With such a wide variation of clinical symptoms and signs, the diagnosis of thyrotoxicosis, and more specifically thyroid storm, is quite difficult, especially because there's no lab cutoffs. There is no lab cutoffs that exist that say, at this level of T3, T4, you can expect this to be thyroid storm, and below this level, you can say safely that this is not thyroid storm. Instead, the diagnosis is a clinical one, with biochemical markers as supporting evidence. But apart from clinical acumens, there's two scoring tools that we can use to help us make the diagnosis of thyroid storm. There's the Birch-Wartofsky point scale and the Japanese Thyroid Association scoring tool. The Birch-Wartofsky point scale for thyrotoxicosis is a diagnostic tool that was created in 1993 by Dr. Birch and is used in the setting of biochemical thyrotoxicosis in patients aged 18 and older. The objective of this scoring tool is ultimately to give you a likelihood that this is thyroid storm presenting in front of you. It was created based on a retrospective analysis of patients diagnosed with thyroid storm and was validated retrospectively against their medical records. This is the scoring tool that is approved for use, essentially, by the American Thyroid Association in their guidelines that have been published in the last 10 years. And ultimately, this tool is quite easy to use. It relies on a mixture of clinical signs and symptoms to achieve a score indicative of the likelihood of thyroid storm. So things such as scores are given, for example, for temperature, CNS effects, GI and hepatic dysfunction, heart rate, stage, AFib, and precipitating events. A score less than 25 is considered to be unlikely thyroid storm. A score between 25 and 45 is equivocal, and a score more than 45 is likely. In comparison, the tool by the Japanese Thyroid Association that was published in 2011, or the GTA, is a tool that ultimately classifies individuals based off of 5 symptoms. Those 5 symptoms are central nervous system manifestations, so things like delirium, altered mental status, or coma, fever, tachycardia, presence of congestive heart failure, or presence of GI symptoms. And based on a combination of those 5 symptoms, you get classified into TS1 or TS2. TS1 being that you likely have thyroid storm, and so you need either CNS plus 1 of the other symptoms or more than 3 out of the 5 symptoms. And then TS2 being the classification saying that maybe you have thyroid storm, but it's a little bit flu. Ultimately, both these tools have been shown in the literature to have high sensitivity but very low specificity for thyroid storm. And so they should be used with caution. For example, sepsis with multi-organ failure could easily score more than 45 on the BWPS score. Therefore, a score of more than 45 doesn't prove a diagnosis of thyroid storm. A recent study of 125 patients hospitalized with a clinical diagnosis of thyrotoxicosis with no evidence of thyroid storm noted that 20% were identified as having thyroid storm according to the BWPS, and 16% had a diagnosis of thyroid storm as per the TSA, or GTA, sorry, thus demonstrating that both tools tend to overdiagnose the entity of thyroid storm. As to which tool we should be using in the emergency department, data comparing the two diagnostic systems suggests an overall agreement between both options. A recent study was conducted with 25 patients with a clinical diagnosis of thyroid storm, and 20% had been identified as having thyroid storm with the BWPS, whereas a total of only 15 had been diagnosed using the GTA score. And so one could argue that BWPS should be the one that we're using. Ultimately, as was already discussed, these tools are just there to support us, and I'm advocating today for the use of BWPS simply because it just makes a lot more sense, and it also is on MD Calc. And so for those who need a quick bedside tool, this is the easiest way to use it, as the GTA tool actually is quite difficult to find in the literature at this time. I actually asked one of our local endocrinologists, Dr. Tran, about the utility of the scoring systems. And he ultimately agrees at the sentiment that they are there to help guide our clinical likelihood of thyroid storm as an entity, but that these tools should not be used to rule in or rule out the diagnosis. His key message is really that they're not perfect and they don't replace clinical judgment, because thyroid storm is a clinical diagnosis. However, he does say that they can provide us with a starting point to help assess the severity of a case. So when talking to endocrinology, for example, saying, I think I have a likely thyroid storm, and their BWPS score is above 45, grabs their attention to say that this is a likely thyroid storm, even using those clinical tools. All right, and this takes us to the end of Objective 1, back to basics. And so let's go over what we should remember from this section. First, remember that hyperthyroidism is a spectrum, and that the resulting clinical syndrome of thyrotoxicosis also exists along a continuum. Remember that thyroid storm is a clinical diagnosis, and one that we need to identify quickly to be able to prevent high mortality and morbidity. And remember that not everyone will present in hyperactive delirium, and that apathy in the elderly is often associated with hyperthyroidism. Your hypoactive deliriums that you see in OBS should therefore likely be getting screening with TSH and T4 levels if they haven't been done in the last month. All right, now that we've learned how to identify thyroid storm, it's now time to consider specific clinical scenarios in which the diagnosis of both thyroid storm and/or thyrotoxicosis should be entertained, especially when it comes to the emergency department. If we all look back into our distant memories, we can hopefully remember from medical school that the top 3 causes of hyperthyroidism are Graves' disease, toxic nodular goiter, and toxic adenoma. And ultimately, these are diagnoses that, apart from maybe some classic symptoms that we see in Graves' disease with the exophthalmos and the thyroid bruit, that we as emergency physicians are not diagnosing in the emergency department. Instead, we will be diagnosing hyperthyroidism, thyrotoxicosis, and its continuum, and we'll be referring on to our lovely endocrinology colleagues for further workup. However, to be able to diagnose hyperthyroidism and its many entities, it's essential for us to think about the diagnosis so that we're able to test for it. And we do so based off of clinical suspicion. So, for example, the classic patient with exophthalmos coming in with palpitations, tachycardia, diarrhea, and weight loss. But patients don't read the textbook. And so where else should we be considering hyperthyroidism in our differential? My hope today is to go through a few of those particular situations in which the diagnosis of hyperthyroidism and resulting thyrotoxicosis or thyroid storm should be part of your differential. The first clinical entity that I think we as ED physicians need to be aware of is the incidence of thyrotoxicosis with amiodarone. As we all know, amiodarone is an antiarrhythmic drug that mainly affects potassium channels and prolongs the repolarization phase of the action potential. It's a medication often used in the treatment of ventricular dysrhythmias by our cardiology colleagues. And it is important with regards to thyroid function, as amiodarone directly affects iodine substrate used in the production of thyroid hormones. In the literature, an incidence as high as 10% is quoted for thyrotoxicosis secondary to amiodarone use. As has already been mentioned multiple times, iodine is an essential substrate to the production of T3 and T4 within the thyroid. In a normal 200 milligram maintenance dose of amiodarone, the equivalent of 6 milligrams of free iodine can be found. The increased presence of iodine can lead to increased thyroid hormone production and overt hyperthyroidism in those who already have pre-existing underlying hyperthyroid state. This phenomenon of excess thyroid hormone production due to excess iodine is known as the Jode base-down effect, and also presents itself following IV contrast loading. This particular effect is more prevalent in iodine-deficient regions, where individuals may be more sensitive to exogenous iodine sources. If it were to occur, the Jode base-down effect secondary to amiodarone treatment has a median discovery time of 3.5 months after amiodarone initiation. But the reality is that here in North America, where iodine-rich food products are abundant, hyperthyroidism from amiodarone iodine loading may not occur as frequently. Caveat being to remember at-risk individuals who have poor nutrition, for example, the elderly, homeless individuals, or immigrants. Instead, amiodarone may also induce hyperthyroidism via a second mechanism, direct toxicity and follicular injury at the level of the thyroid. This injury tends to accumulate over time, and as such is often seen approximately 30 months after the amiodarone was initially started. In this particular entity, apart from typical thyrotoxicosis symptoms, individuals may also describe anterior neck pain. So we know that amiodarone can induce hyperthyroidism through either the iodine loading and availability of iodine substrate or through direct follicular cell injury, and that the presentation of hyperthyroidism secondary to amiodarone can occur over several months to years since initiation of amiodarone. This is actually why routine screening Q6 month of TSH and T3, T4 is recommended by the Canadian Journal of Cardiology and the Canadian Cardiovascular Society. However, if the pandemic has taught us anything, it's that our healthcare system is precarious and things fall through the cracks. As such, when should we as ED physicians consider the diagnosis of amiodarone-induced hyperthyroidism? Because it's not simply feasible for us to be the ones to be doing routine screening. Ultimately, the potential diagnosis of amiodarone-induced hyperthyroidism should be considered in the following situations: tachycardia in a patient on amiodarone with no obvious underlying cause to explain that tachycardia; weight loss and generalized weakness in the patient who has been on amiodarone; and of course, if someone presents with classic thyrotoxicosis features, then of course you should be considering the diagnosis. So say you thought about it, you tested for it, and now you have diagnosed hyperthyroidism likely secondary to amiodarone. What next? Ultimately, step 1 is to stop the amiodarone. And step 2 is to actually send off a call to your friendly local neighborhood endocrinologist. And so speaking with Dr. Tran from endocrinology, he basically said it's just best to call us for advice, because they actually will offer to start methimazole and prednisone right there in the emergency department and will advise us on the doses to do so. He basically said that at any time, if you have any questions about any hyperthyroid or thyrotoxicosis case, to give him a call. Not personally, but give the endocrinology unit a call. And they're happy to kind of advise us on steps moving forward. All right, COVID-19. I know we're really sick and tired of this topic, but it's really important for us to go through it with regards to thyroid, because in the last 2 years, a lot has been published on the topic. For those who have looked at the Lit COVID website database by the NIH, there's actually been approximately 114 publications in the last 2 years relating to thyroid and COVID-19. A large proportion of observational studies have identified that most patients with COVID-19 present with euthyroidism or euthyroid-sick syndrome. Ultimately, these individuals just have mild reductions in TSH and T4 with non-thyroid-like illness syndrome, and ultimately have most of their values returned back to baseline after several months. However, what's more important for us today is that there has been several case reports and now observational studies that have demonstrated that COVID-19 is a cause of subacute thyroiditis. For subacute thyroiditis, there's essentially a primary inflammation of the thyroid after an upper viral respiratory infection that causes a mild thyrotoxic state. This is something that has been seen in other viruses apart from COVID-19. Inflammation and swelling of the thyroid causes a stretching of the thyroid capsule, which leads to pain. Although in certain contexts, such as the postpartum period, pain may not actually be present. It's really unclear actually if viral subacute thyroiditis is due to direct infection of the gland by a virus or its reaction to cytokines such as IL-6 during the viral infection period. But the reason COVID-19 is so interesting is that COVID-19 actually enters human cells through ACE2 receptors, a receptor that is actually expressed on the surface of the thyroid follicular cells, making thyroid tissue a likely and possible target of direct infection by the COVID-19 virus. This is why, back in 2020, Muller and al. Actually discovered the evidence of possible subacute thyroiditis connections with COVID-19 in ICUs in Italy. They found a signal for a large proportion of COVID-19 patients in intensive care who had thyrotoxicosis with low TSH secondary to suspected subacute thyroiditis. Subsequent to this Lancet paper, a single-center retrospective study was conducted and directly sought to evaluate thyroid function in relation to interleukin-6 in hospitalized patients in non-ICU settings. Of 300 enrolled patients, 20% were found to have overt thyrotoxicosis, 5% had hypothyroidism, while the remaining 75% had normal function. They also found that TSH values were inversely correlated with age and IL-6. IL-6 being a potential cytokine responsible for the inflammation of the thyroid tissues. And this study ultimately proved to us tangible evidence that COVID-19 was associated with high risk of thyrotoxicosis in relation with systemic immune activation induced by the COVID-19 virus. And so why does this really matter? With such a high proportion of individuals who have COVID-19, are we really going to be screening every single patient that comes through our doors with a COVID-19 infection? The reality is, no, we're not. That's too many people. And also because right now the literature, like I said, is basically focused on case reports and observational studies. However, subacute thyroiditis is something that is present in COVID-19, and it should be considered, especially in individuals who present with tachycardia without any suggestion of progression of their COVID-19 disease, or in the absence of common other causes of tachycardia post-viral illness, such as PE or pericarditis. And tachycardia in particular is a symptom to watch out for, as retrospective studies conducted in the US have identified that tachycardia has a sensitivity and specificity for hyperthyroidism of 70% and 62% respectively. And so think of that classic patient you see in the emergency department, post-viral illness, post-COVID, coming in with tachycardia. Most of us will do a pericarditis, myocarditis workup in addition to potentially some PE screening as well. And I want you to encourage to think about sending a TSH off as well for this patient, just due to that increased risk of subacute thyroiditis that is present. The other person that you should consider potentially screening for this is anyone who's had COVID-19 with anterior neck pain, as we know that thyroiditis will cause pain in this population, except for in the postpartum period. But if you forget that, that's not the end of the world. So just remember that next time you're working someone up for a PE or pericarditis in the context of COVID-19, make sure to keep in mind that thyroiditis as it is, keep in mind thyroiditis as an entity. Documents have shown, or observational case reports have shown, that you can get thyroiditis for up to 3 months post-infection. And so something to consider in the kind of acute but also subacute period following the viral illness. All right, we've spent a bit of time, quite a bit of time exploring two entities that often lead to thyrotoxicosis in the ED. But let's quickly review a few clinical scenarios in which the diagnosis of thyroid storm in particular should be considered. So the first is a patient with known hyperthyroidism with an acute clinical illness or deterioration, someone who has new onset atrial fibrillation and or new onset dilated cardiomyopathy, someone with new onset delirium and psychosis with abnormal vital signs, hyperthermia, mainly with a temperature above 40, and a septic appearing patient without any focus of infection. And that brings us to the end of step 2. So remember, amiodarone with tachycardia, someone on amiodarone with tachycardia, weight loss, and other features of thyrotoxicosis, you should consider the diagnosis of thyrotoxicosis in this individual. The other patient you should think about is your post-COVID patient who presents with tachycardia and anterior neck pain. And step 3, but last but not least, our last objective of the afternoon, or the morning, I should say, is to go over the treatment of thyroid storm. And so ultimately, the treatment of thyroid storm is a 3-step process. And it should be as easy as 1, 2, 3. But what really is that easy in medicine? So step 1 is to provide supportive treatment for your individual. Step 2 is to identify and reverse any potential triggers. And step 3 is to use directed, targeted thyroid-specific treatments. Note that treatments such as thyroidectomies and definitive treatment will not be covered in this presentation because these occur much later on in presentations. So let's get started. Supportive management should always be your first step in the management of thyroid storm. Using your ABC approach, you will provide supportive management for the patient in front of you, who often will be agitated, febrile, and may even be hypotensive. Management options may include antipyretics, fluids and pressors, and sedation for agitation. Because ultimately, usually when these patients roll through our doors, we don't know that they have thyroid storm initially. So make sure that you are also ruling out toxidromes, covering with broad-spectrum antibiotics, and supporting hemodynamics as required. As a general rule, however, remember that if you are considering the diagnosis of thyroid storm, avoid the use of NSAIDs or aspirin due to their theoretical risk of increasing free thyroid hormones levels by displacing thyroid hormones from their protein binding sites. The second step is to identify reversible triggers. Oftentimes, this is infection, and a full septic workup is essential. Other considerations, though, include surgery, trauma, MI, strokes, DKA, and hypoglycemia. In addition to thyroid-specific precipitants, such as recent thyroid surgery, discontinuation of antithyroid medications for those who have Graves' disease, thyroid hormone overdose, aspirin overdose, or an iodine load. It's important to remember, however, that in retrospective studies, up to 30% of thyroid storms do not have an identifiable trigger. Of note, however, a retrospective multi-center study conducted between 2000 and 2017 in 31 French ICUs examined 92 patients with thyroid storm and identified that amiodarone-associated thyrotoxicosis and Graves' disease represented the main thyroid storm etiologies, and that amiodarone use and antithyroid drug discontinuation were, as a result, the main thyroid storm triggering factors. So make sure to screen for those two things. Step 1 and step 2 sound easy. Now let's get on to step 3. This is where the discussion gets a little interesting. The third step really requires you to use specific targets to the thyroid. And to remember what you need to do, all you need to remember is the 5 Bs. When treating thyroid storm, one should think of the 5 Bs as follows. Block synthesis, block the release, block T4 to T3 conversion, block beta, and block enterohepatic circulation. So blocking the synthesis. We'd like to block the synthesis of T3, T4 by using antithyroid medications, including PTU and methimazole. These antithyroid medications inhibit thyroid hormone synthesis by acting on thyroid peroxidase. It has traditionally been recommended that PTU is preferred over MMI due to its effect on peripheral conversion. In addition, early research into acute changes in thyroid hormone level after initiation of PTU or MMI found that T3 levels drop by approximately 45% in the first 24 hours of PTU therapy, compared to approximately 10 to 15% in the methimazole group. However, PTU does have some disadvantages in that it is associated with a high proportion of liver failure and is not continued upon discharge from hospital. Everyone gets transitioned from PTU over to methimazole on discharge. And ultimately, there's actually no head-to-head trial that has demonstrated clear superiority of PTU over either carbimazole or methimazole in thyroid storm and thyrotoxicosis. As a result, many experts, as well as many different associations, including the American Association of Endocrinologists, now actually recommend the use of methimazole over PTU in thyrotoxicosis and thyroid storms. The caveat being that if you have an individual who's in the first trimester of pregnancy, you must use PTU due to neural cord defects with the use of MMI. The other thing is that those initial studies that were done more than 40 years ago showing that PTU decreased thyroid hormone levels much quicker than methimazole are still present. And so in people who are in overt cardiogenic shock as a result of thyroid storm or are quite ill, they still do suggest the use of PTU in that entity. For those who are studying for the exam, these are your doses. For those who are not studying for the exam, EPIC has this as a whole set for you. And just remember, if you have if you are first trimester pregnancy or you have a really bad storm, that you should actually consider using PTU despite the guidelines stating that MMI is your first line at present. Your antithyroid medication is your first line treatment for thyroid storm and should be initiated as soon as you have identified thyroid storm as your entity. There's a couple other things that you can do, however, and it revolves around your 4 Bs. Takata and al. In 2010 demonstrated that 15 milligrams a day of MMI combined with potassium iodide was significantly more effective in achieving a euthyroid state and had fewer adverse effects than using MMI alone. However, we need to remember that you need to be aware of the Jode base down effect that we talked about earlier. As we discussed, a significant iodine load, especially in individuals who are iodine deficient or have toxic nodular goiter, may upregulate the production of thyroid hormones. For this reason, it is imperative that you provide the antithyroid medications prior to giving the iodine. And you need to give the antithyroid medications at minimum 1 hour to work. As the iodine load is increased, in particular in individuals with no iodine deficiency and a otherwise working thyroid, the inverse of the Jode base down effect occurs, and this is why iodine works. In normal individuals, excess iodine inhibits thyroid hormone synthesis through the Wolff-Chaikoff effect. For those who are studying for the exam, your iodine dosing is as follows. But just remember, if someone has an allergy to iodine, you can also use lithium carbonate, which inhibits essentially the TSH-mediated CAMPA signaling. And just to remember, do not give iodine until at least a minimum 1 hour after you've given your antithyroid medications. A hot clinical pearl that was given to me by one of the ICU fellows recently is that actually when you order your medications, don't order your iodine up front because it typically will come up first from pharmacy compared to your antithyroid medications. And so as a result, just don't order your iodine, order your antithyroid medications, order all your supportive care, and worry about ordering the iodine later because it's not important in the moment. And the last thing you want to do is give someone the iodine before the antithyroid medication because you're going to get yourself into a whole lot of trouble following that. All right, step 3, you're going to block the conversion of T4 to T3. We use steroids to do this, and they have the added benefit of actually helping as well in relative adrenal insufficiency secondary to the hypermetabolism of thyroid storm. There's not much evidence for the use of steroids that I could find in the literature, but ultimately everyone should receive the following doses. So everyone should receive hydrocortisone 300 and then 100 milligrams TID following. The 4th step in your management of thyroid storm is beta blockade. And this is the one that is probably the most controversial and interesting with regards to thyroid storm management. The reason we use beta blockade is simply for symptom control. Tagami and al. In 2012 found that in patients with Graves' thyrotoxicosis, a combination of an MMI, which is your antithyroid medication, with propranolol or atenolol significantly improved heart rate and subjective symptoms such as tremors, and overall improved the quality of life of patients. However, it had no effect on the thyroid. And ultimately, all of the research has been done mainly in mild thyrotoxicosis cases, not in flagrant thyroid storm. And so why should we be hesitant about starting beta blockade in the emergency department? Well, because beta blockers are a double-edged sword, as we know. In the literature, there are innumerable cases of precipitous decline and subsequent death of individuals treated with beta blockers in the context of the thyroid storm. Most recently here at TOH, we've had one of those deaths in the last 4 years, when an individual was started on propranolol for their thyroid storm. Considering the high heart failure rates in our community, and the outcomes of cardiogenic shock, Beta blockers should be used very cautiously in the emergency department in the diagnosis of thyroid storm, because as we know, the negative inotropy of beta blockers often precipitates cardiogenic shock and pulmonary edema and subsequent decline. And this is where we as emergency medicine physicians play a pivotal role in this aspect of thyroid storm management. We are the ones who are at bedside. And so it's important when you have a thyroid storm case to go through the following things. Remember your ABCs and identify that the patient is in shock. You should fluid resuscitate as needed and provide your doses of steroids in addition to the rest of the management we already discussed. But you should really be using your tools. Take a look at the heart, perform a quick bedside echo and lung ultrasound to assess the risk of cardiogenic shock. And make sure that you do a volume status assessment as well to replace hypovolemia as a possible cause of your shock. And ultimately, if in any three of these steps here, you identify that there is shock with evidence of LV dysfunction or biventricular dysfunction, or there's evidence of flagrant cardiogenic shock with pulmonary edema, then beta blockers should not be used in the treatment of thyroid storm because you will precipitate the clinical demise of this patient. In talking with our local expert, Dr. Ariel Hendon, she basically explains the following. If a patient is hypotensive and tachycardic with thyroid storm, worry about cardiogenic shock. Treat them as any other cardiogenic shock and think carefully about giving antibiotics and steroids. Ultimately, we should not be pursuing rate control in these individuals. This is a potential, these are patients that are at potential of teetering over the edge and decompensating if we give them negative inotropy. And so ultimately in the guidelines, it says it's the fourth step, you should be giving beta blocker, but today I'm here to tell you that you shouldn't. If you have a thyroid storm patient, you should be avoiding beta blockade, especially in the context of being concerned about cardiogenic shock and pulmonary edema. All of the literature has shown that beta blockade improves symptoms, mainly in mild cases. And so in the acute phase, avoid the beta blockers, forget about them, resuscitate your patient as usual, and we can worry about adding beta blockade later in the clinical course to help the patient with their symptoms moving forward. If at any point you do need, however, to rate control an individual because, for example, they're so tachycardic that they aren't getting enough filling time, then the use of esmolol is probably your best bet because it is a quick on and a quick off. And last but not least in our 5Bs is blocking hepatic circulation. And for that, we use cholestyramine. In a randomized control study trial by Sayanyl in 2005, they demonstrated that patients with Graves' hyperthyroidism who had treatment with PTU, propranolol, and cholestyramine had a significant decrease in T4 and T3 at weeks 2 and 4 compared to those who did not have cholestyramine use. And so as a result, cholestyramine is often used in the treatment of thyroid storm. And it should be started as soon as possible to help decrease essentially the thyroid hormones in an acute fashion. It's dosed as 4 grams QID until the thyroid storm resolves. And so that brings us to the end of thyroid storm management. So what do we need to remember? We need to remember to treat the patient that is in front of us. And so your first step is always going to be your acute resuscitation. Your second step is to find an identifiable source to reverse. And then after that, you should consider your 5Bs, which are your direct thyroid treatments. So you're going to think about blocking synthesis, blocking the release, blocking conversion, blocking beta, and blocking hepatic circulation. But ultimately in the emergency department, the 2 things that we are likely going to be doing are the 2 that are highlighted in red. And so blocking synthesis, as we discussed, is the most important step. You want to stop the production of thyroid hormones by using either methimazole or PTU. Remembering that you should be using PTU in the first trimester, and that if you have a really bad thyroid storm, that PTU might have a better effect than MMI. The second red box is blocking beta. And the reason it's highlighted in red is because we are the ones that are at bedside. We are the ones who are clinically evaluating the patient. And so when discussing these cases with endocrinology, if suggestions for beta blockers is brought up, use your clinical judgment and discuss the case with endocrinology as to why beta blockade may not be useful. As discussed in bad thyroid storms, cardiogenic shock is a very real entity, and as a result, beta blockers should not be used for rate control unless absolutely required due to decreased filling time. And in that case, esmolol should be used. The other thing to kind of remember and consider is that blocking the release may be something we do in the emergency department, depending on how long they stay with us, and that iodine should be ordered after antithyroid medications have been delivered. And they should not be given until 1 hour after to ensure that you're not getting a floodgate release of thyroid hormones. And just another plug to stop and think about beta blockers. All right, so let's get back to our case. As a refresher, Doris is our 65-year-old female who presented to hospital with generalized weakness, decreased appetite, nausea, vomiting, and low-grade fever. She had no objective sources of infection that were found on her examinations, and she had a CT abdomen which ruled out any obvious colitis. Being the astute ED physician that you are, you had actually sent off screening blood work given there was a new presentation of atrial fibrillation, and your blood work revealed that she had an undetectable level of TSH. You appropriately fluid resuscitated her and provided supportive adjuncts and promptly started her on antithyroid medication. PTU in this case, only because you were in a peripheral hospital that didn't have methimazole. You called through critical and had the patient transported to the nearest tertiary care center, and esmolol was available upon transfer, but was never used. Post-discharge from ICU, the patient was started on propranolol for her symptoms and had an uneventful clinical course following. So I hope that you have enjoyed today's Grand Rounds presentations, where we had the opportunity to explore the pathophysiology of hyperthyroidism, reviewed possible clinical entities in the ED that should make you concerned about thyrotoxicosis or thyroid storm, namely amiodarone and COVID-19, and reviewed a step-by-step approach to the management of thyroid storm. I'd like to take this time to thank the individuals on this slide here, namely Dr. Lauren Lacroix, who is my supervisor, Dr. Alex Tran from the endocrinology unit, and Dr. Ariel Hendon as expert content. And I want to thank all of you for your attention today. References are available by the QR code here, and I'm happy to take any questions.